Hey nursing friends, welcome back to my channel. If you're new here, I am Tochi. I'm a nursing student, and this is my Study With Me series where we learn together. Today is part 2 of burn units, burn injury, and honestly, this is where it gets real. Like, we're diving into wound care, skin grating, and all of those complications your professors love to test on. Last week, in part 1, we covered burn type, classification, the rule of knives, and fluid resuscitation with the Parkland formula. If you missed that, I'm going to be adding the link up there somewhere, and you will want to watch that first because we're building on it. Now, here's our game plan for the next 30 to 45 minutes. We're going to be talking about wound care management, skin grafting techniques, complications to watch for, rehabilitation and discharge planning, plus practice questions and NCLEX style. Grab your coffee, grab your tea, like I am. I'm currently with my tea here because it's quite cold. So, with my very hot tea, I even have a flask right there beside me. Let me show you. So I can make more tea. And let's do this together. And hey, if this video helps you, smash that like button and subscribe so we can keep learning together. Okay, let's go. All right, our first step is going to be wound care. Wound care is huge because infection is number one cause of death in burn patient after the first 24 to 48 hours. The three main goals of wound care, you need to know this and write this down. Remove non-viable tissues. We call this debridement. 2, you want to promote reepithelialization. Basically, that's just saying that you want new skin to grow back. Number 3, you want to cover the bond area. You want to protect it, and you want to eventually graft if needed. Now, here's something your clinical instructor would definitely ask about in your exam: hydrotherapy. Hydrotherapy is basically wound cleansing in a controlled environment. We're doing this to clean the wound, prevent infection, assess wound healing, reduce scarring and contractures, not chins, contractures. Always pre-warm the room before wound care. Why? Well, because this patient lose body heat so easily. Remember those two cases in your notes. One patient came in with a core temperature of 88 degree Fahrenheit after a 40-minute ambulance ride. Hypothermia is real. Now let's talk antimicrobial agents. The most common you see is silver-based agents. These are your besties, like your real besties. Silver sulfadizine. So silver sulfadizine is like also known as silver diamine, silver nitrate, methionite acetate. That's also known as sulfamaleon. Know this for your exam. Silver agents have broad spectrum antimicrobial activity. They penetrate eschar. Remember, eschar is like the black part of a wound. You can That's unstageable, the eschar part. So it penetrates through eschar, that thick, leathery, dead tissue. Now, there's open versus closed method. Open method is when the wound is exposed to air after antimicrobial application. pros, there's always pros and cons to everything. So the pros for this one is easy to assess. The cons is you're in higher risk for infection and heat loss. Now, for the closed method, this is when it's covered with dressing. Your pros, you're protecting the wound, you're maintaining moisture, and your cons, you cannot see the wound as easily to assess. Is it getting better or is it getting worse? Now, look at these examples that I'm going to try to show you, but if not, just think of it. John was treated at a local clinic 1 month post injury versus Paul, who was treated at a burn center 3 weeks post injury. There's a difference. Okay, so this is what I was talking about. Hydrotherapy, you're going to protect yourself and you're going to like on the patient, you're going to like pour the water. This is how the room is set up for it. It's very like it's a very sterile procedure. This you have to wear like these bags and everything to do the hydrotherapy. This is kind of what I was talking about. This is a patient that is treated at a local clinic 1 month post injury of the burn. This looks like a scarring burn versus another patient that was treated at the burn center, and this is 3 weeks post injury. Do you see this is open and then this is closed? Because they specialize at that, like in the bone center they basically specialize at this type of injury, so they know the best way to do your treatment, personalize it to make you heal faster. Basically that's the difference I'm trying to show you, and also the different type of wound healing. So specialized bone care can make a massive difference in outcome. Now, your patient has a 35% total body surface area burn. Um, During wound care, you notice the room temperature is 68 degrees Fahrenheit. What do you do first? I'm going to pause for a minute to let you think about that question. Let me repeat it. Your patient has a 35% total body surface area burn. During wound care, you notice the room temperature is 68 degrees Fahrenheit. What do you do first? Now, you got it. You need to warm up the room. You need to prevent hypothermia. The patient, this is patient safety 101. Okay, now I'm going to move on to skin grafts. Okay, this is the part that looks scary but is actually so fascinating. Skin grafting. Oh, I forgot to tell you guys. Burn has a lot of pictures. Like I could be talking about it, but you won't really understand it until you see the pictures and you can like click it to like together. I don't know if you guys if they do this for you guys, but when sometimes when we do exam they put picture and they're like, okay, what stay like and they ask you what do you think this is, or what are the assessment you need to do for this patient just based on the picture, and all of those things. So it's kind of help to like have an image to like know what you're doing. But another thing is because this is born, it's not fancy, it's not pretty, it's like really gruesome. So we're in the healthcare system, so we're gonna be seeing things like this. So this is not for the faint of heart, is basically what I'm trying to say. So prepare and you're gonna see things, okay? Okay, so this is just a heads up. Okay, now moving on. First question, who needs a skin graft? So we have deep partial thickness burn, all full thickness burn and burns that won't heal in 2 weeks. Let me emphasize. Here's the deal. Autografts are the only permanent method. Write that down. Autograph, like autograph. Now, autograph is your own skin is transferred from one area, donor site, to the bone wound. Where do we harvest from? Usually the thigh, the buttocks, or the scalp. Areas with good skin quality that can be eaten. Now comes the cool part. There are two types. There's the sheet graft that is non-meshed, and then there is you and then there is the mesh graft. Now let me go into detail. The sheet graft, the non-meshed one, is used on face and hands. Why? Better cosmetic outcome. It looks more natural. No mesh pattern scarring. Now, mesh graft is used on larger body areas. The dermatome cuts tiny slits in the skin and it allows it to expand like a net. It covers more area, but it leaves that mesh pattern scar. Now, we're going to try to look at, let me see if I can find it. Never had the opportunity to see one in person, but this is how it goes. Do you see that? That is them using the machine to like cut it from donor site that's on the patient body, and then they're going to put it on the mesh. Let me show you the next slide. That is it when this is a mesh pattern. You see how it looks? So that scar stays with them. It heals, but it stays with them. Let me see if I have another good picture. So this is how it is. This is it when it is healing. This is the healing. You can't really see the mesh pattern, but it's there. Do you see that? But this is it during the surgery. And yeah, okay, let's move on. Okay. Now, sometimes let's not go beyond our side. So I hope those pictures help. And now the hands look so much smoother. That's why they're very picky about which type we use. Now, donor site. This is a surgical wound, friends. It's painful and it needs special care. You want to treat it like partial thickness burn. You want to keep it clean and covered. It usually heals in 10 to 14 days, and you can harvest from same site again after healing. Your patients would tell you the donor site hurts more than the burn site sometimes. Why? Because the burn might have destroyed nerve endings, but the donor site, all those nerves are intact, and they're not happy with you. They're very, very unhappy because, Now, benefit of early grafting. If you can, memorize this list. Speeds healing. Early grafting would speed healing. It will reduce hospital stay and less costs because insurance. We always have to think of that. It decreases pain. It reduces hypermetabolic states, and it lowers infection risk, less scarring, and better functional outcome. That is why burn centers push for early excision and grafting, usually within the first week if the patient is stable. Nursing care post graft. You want to keep graft immobilized. You want to elevate to reduce edema, and you want to monitor for signs of infection. You want to watch for hematoma or seroma under the graft. No pressure on fresh grafts, and donor site care is crucial. Not just only the site of the bone, you also have to care for where the skin was taken to cover the bone site. So now the you might also see negative pressure wound therapy is like that sponge with suction tubing. This removes edema, it stimulates blood flow, it creates a closed healing environment, and it can be used on wounds or on grafts. So this is the idea of the negative pressure wound. This is the skin. So this is the thing, and then they put that suction cup to like, oh shoot, sorry, to like take it out. So do you see it? Basically, that is to help remove the fluid and wound exudates, like the wound debris and fluid exudates. So it's like it hastens the process. So yeah, this is a really good image of it. So, and I wanted to say there's some situation where they allow the bone to heal without doing skin graft, and these are examples of pictures of that. They allow it to heal without graft. It's always depending on the situations and stuff. So yeah, this is an example of how a deep second and third degree burn look like on the face. Remember when I said if you have any burn on the face, it's like it's really important. You need to make airway and everything. Okay, but that's if you watch the part one of the burn series, I go into thorough detail about that. Anyways, moving on. If your patient is scratching near their graft, stop them, because disrupting that graft in the first 72 hours can cause complete graft failure. We need those new blood vessels to grow in and anchor it. So basically, if need be, you could restrain the patient or you could put down maintenance on them, but yeah, you need to stop them from itching that place. They cannot spoil. It needs 72 hours to grow in and attach. Now, real talk, burns have a lot of potential complications. Let's break down what you need to watch for. With everything, this is skin. Remember, skin is like the big barrier, and a lot of amazing functions the skin does for us. So one of the big things to watch for would be infection. Number one cause of death after 48 hours, higher risk with above 30% total burn surface, total body surface area burns, higher risk with above 30% total body surface area burns. Why? Because skin barrier is destroyed, which then causes immune suppression. So you want to watch for signs to watch for include increased wound drainage, color changes, green, brown, black, foul odor, fever, increased pain, conversion of partial to full thickness. Your priority, sterile technique, always. Infection control is not optional, it's necessary, it's compulsory. So, compartment syndrome. Remember this from part one. Conferential full thickness bond act like a tourniquet. What to assess for? Our 5 Ps. 5 Ps. 5 Ps include pain. want to assess for pain. You want to assess for pallor. Pallor is like, are they pale? You want to assess for pulselessness, but that's more critical. That's late sign. That's, you feel for their pulses and you don't feel pulse. That's like way late. You want to assess for paresthesia. Paresthesia is that pin needle feeling. I don't know if, okay, I had that feeling once. I have it most especially when I like sit on my, like when I cross my leg and I sit on my leg, like, like in a meditation type of way, or yoga type of way, and I stay for that in that position for a long time. When I stand up, I feel like pins and needles stick, like that feeling. You have to have done something to feel that tingling, like sharp feeling. And then we have paralysis. Now, we also want to assess for decreased capillary refill. We want to assess for numbness, tingling. If you see this, you want to notify the provider ASAP, immediately. Starts. Treatment is escharotomy or fasciotomy. That's the surgical release of that tight eschar. Okay, let me see if I have an image of fasciotomy. So I went to go consult the book, the textbook, my textbook, the current one I'm using, Soul's Introduction to Critical Care Nursing, 9th edition, and I found escharotomy. So this is how it goes, because I googled it, but the pictures on Google were like really not nice to show. So, but this one is a good example of how it looks like. So they basically like cut it up to like release that pressure of eschar. So I needed to show that so that you could understand what I was talking about. So we have as case study a 30-year-old with electrical burn who got a fasciotomy. What you're looking for, pedal pulses, decreased pain, and no swelling to know if it worked. Like after the fasciotomy, what you're looking for the pedal pulses, that's the leg. You're looking for decreased pain and no swelling around that area to know if it worked. Now, we also have abdominal compartment syndrome, and this one is very sneaky because it's from convergential torso bonds. Remember, torso is 18% in the front, 18% at the back. So torso, aggressive, you need to do aggressive fluid resuscitation, intra-abdominal pressure. If it's above, greater than or equals to 20 mmHg. Now, you want to watch for tense abdomen. You want to watch for decreasing urine output. You want to watch for hypoxia. And you want to watch for high CO2 levels. We have coiling ulcers, that's GI bleeding. That is basically stress response causes. It decreases blood flow to GI tract, increase gastric acid, ulcers form. Prevention is basically feeding, nutrition. Remember, we did nutrition, a very important topic. Early enteral feeding, protopump inhibitors or your H2 blockers. And you also want to monitor for occult bleeding, then contractures. As wound heal, scar tissue tightens. Now, you want to and when that happens, it limits the range of motion, as is especially bad over joints. It can be permanent if you're not actively trying to prevent it. Your prevention will be early physical therapy. We want to get this patient up and moving. We want them to do our roam. We want them to do prone. Active range of motion, passive range of motion. You want to do positioning, you want to do splinting, you want to do compression garments, your SCDs, your compression, those compression socks. This is why rehab starts day one, not after discharge, right as you're treating that patient, you're doing it. Now, psychological complications. Don't forget, burn affects the whole person. The psychological complications include depression, PTSD, anxiety, body image issues, social isolation. The entire family is affected. Long-term psychological support is essential. Now, quick section here on special population because the patients need extra attention. Okay, there we go. Pediatric burns. 30 to 35% of burn patients with are pediatrics. 80% of pediatric burns are scarred burns. Always assess for abuse. And if the story is not storing, and you're not sure, we are mandated reporters. Report it. The worst that can happen, they'll do the research and nothing is there, and they dismiss the case. But you always want to report. Like if that story is not storing, like, anyways, you want to always assess for burns, and the kids need proportionally more fluid. Red flags for abuse: delay in seeking treatment. So maybe, though, let's be honest, burn, when it happens in the first few hours, it doesn't really show. It's until 24 to 48 hours. I have a picture, let me show you. So I found a really good picture. So you see this patient? Oh Jesus. Oh Jesus. Okay, here we go. This is them on admission. Would you cooperate with me? We're friends here, okay? Okay, sorry, it's taking a minute. There we go. You see, this is an admission. Yes, we can see that there's a burn happening, but it looks not bad. But then 24 hours later, this is how the patient is looking. It's swollen. It's beginning to show. And then this is 48 hours later. Do you see the difference from admission 24 hours and 48 hours later? See the progression? And then we have another one. This is an admission for this little girl. Like, can you really see anything going on here? And then 24 hours later. That is why wound burn is like, it's like really serious. I mean, facial burn, if it happened on the face, yes, we have to take it like really serious. And then this is another one. This is on admission. Does this arm look like, if they went to urgent clinic, well, if they sit it, they're like, okay, they're okay, and just give them maybe something for pain, but nothing, it doesn't bring an alarm until boom, 24 hours later, this is what it's looking like. So that's why it's very important to go to the burn center. If story does not match injury, it's a red flag for abuse. Your red flag should go ding 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 ding. If there's clear demarcation lines, like dunking, there is no splash lines, and there is like stocking glove distribution. Now, I think I have some abuse pictures I'm going to show you, so you know the difference. Like when you see some certain types of burn, you know that yes, this is abuse versus, oh, this is an accident. I know we left fasciotomy and escharotomy, but this is a very good picture on fasciotomy. Like when I talk about abdominal compartment syndrome, this is it. This is what is happening. They're cutting the eschar because it tightens and compartment syndrome. So they cut it open and yeah. So yeah, when I say clear demarcation line, like dunking, this is what I mean. This looks like a child that they put in like in a hot water above 104 degree. Like, do you see it? Like you can see the line that they like placed like into the hot water immersion. Like it has a clear demarcation line. They're like straight line. Like this is abuse. There's no splash sign. They delayed seeking. So if they delayed seeking, so I told you 24 to 48 hours. That's like a day to 2 days, and they did not come until 3 days, 4 days, 5 days after injury. Red flag, big red flag. You see how it's dry, crusty of the wound, and then yeah, and then if you see bruises, fracture, yeah, that is a clear sign of abuse. Let me see if we have another one. Yeah, do you see this? The bun. This. What do you think this looks like? This looks like a bun, like a hot fork. And then they put it on the patient. Oh, damn, that's not nice. And they put it on the on the child to burn them. And then this one is just damn right. Like if you see something like this, please just like look on the butt where they're gonna sit. This child, it's anyways. This is yeah. This is abuse. This is a clear sign of abuse. They literally put this child butt naked on a hot surface to burn the child. Okay, that is it for those ones. It is abuse until proven otherwise. If they can bring a clear, solid of why it's not, but it's abuse. Anyways, elderly burns only 5 to 10% of burn population, but they have higher mortality rate. Their skin is thinner, like thinner, papery, like it feels like when you touch them it's like it's the elasticity is gone, so the bond it when it bonds deeper and healing is slower, so and they are less able to tolerate bond stress. When there's any stress on your body, your cortisol level rises up, and when your cortisol level rises up, your glucose shoots up. When your glucose shoots up, infections are more likely to happen. You see the breakdown there? Anyways, facial burns. Assume when there's anything facial burn, you always want to assume respiratory injury because massive edema is to be expected. I remember seeing those pictures where, oh, they had a bun, but it was like it just only like you think it's only the forehead, but then later on you see them swollen airway, ABCs. Um, you want to elevate head of bed to 30-45 degree. You want to protect the eyes, and oral hygiene is critical. For hand burns, you want to elevate that hand to minimize edema. You want to do early range of motion exercises. You may need sheet grafting for better function. Let me show you another picture of the grafting. This is another autograft. Like, do you see that? Meshed. Mesh is ideal for joint, face, hands, and feet. Injury require more than 2 weeks of healing. And then sheets is the other one where it's really cosmetic, and it's basically for hands or face. Now, this is it. This is when they use the dermatome. Dermatome is the name of the thing. It's like it's like oh, you know when you grate carrots. It's a carrot. Yes, when you grate, oh no, 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 not grate. I do you guys have those potato peelers when you're like peeling the potato skin from the potato? Yes, that's exactly it. Potato. Like when they peel potato using, that is kind of what is happening here. But then imagine it on human being, on human skin. So yeah, that's why when you're caring for this patient, you're not only just caring for the bun side, you're also caring for the donor side too. Let me see if I have another good pictures. Okay, so this is, I said scalp is another good area for uh donor sites. Look, you wouldn't even know that she because her hair covers it, because they took it from a really discreet location, only her knows. And look at how, yeah. And there you go. Let me see. And then this is like compression therapy for burn. Okay. So to continue, hand burns, they need early range of motion exercise, and they might need sheet grafting for better function. Sheet grafting is the one that is not meshed, and splitting to prevent contractures. Now we have electrical injuries. Remember, what you see is not what you get, because it takes time for it to actually show. So what you see is not like, oh, okay, that's it. No, it's not what you get. Entry and exit wound. For electrical injuries, if there's an entry wound, there is an exit wound. Mostly entry, the hand, exit, the leg, the feet. There's deep tissue damage. There is cardiac arrhythmia common, because this is electricity going through your body, and your heart is, so yeah, cardiac arrhythmias. Um, Myoglobinuria risk, that's the muscle, and then need for higher fluid volumes. Your target urine output should be 75 to 100 ml per hour for electrical burn injury patients, not the usual 30 to 50 ml per hour. You want to do more. Now, your patient has survived the acute pace. They got their graft. Now what? The journey is far from over. Rehabilitation pace starts from admission. It continues for months or years after discharge. Goal is to restore functional status, is to prevent contractions, is to minimize scarring, is for the goal is also for psychological adjustments. You want to, and also ease them into returning to work life. Okay, that's where occupational therapy will come in. So physical therapy, occupational therapy. Um, Compression therapy, like I just showed you, is a custom fitted pressure garment. Is 123 hours a day, for 12 to 18 months, and it reduces hypertrophic scarring, and it's uncomfortable but necessary. I don't know if you guys have had to wear Fajer, those compression devices, not device, but it's a compression garment. Fajer, Spanx. Women, if you know are wearing Spanxes, but you get a choice to not wear it away. But this is next compression garment is necessary for them. It's uncomfortable but necessary. And for those that choose to wear Spanx, it's because they want to look, they want to look, you know what I mean. So it's uncomfortable but necessary. I like to connect what I'm talking about to something, so you can always like, oh yeah, this, and join it together. And that it really helps me for my exam. I hope it helps you too. Discharge planning. It requires a multidisciplinary team approach. You want to assess short and long-term disabilities. You want to identify resources, because you're going to be in and out of the hospital a long time. So we want to know what kind of insurance coverage, financial, community. We want patient and family education. We want to know they have a big, huge support system. We want to do home environment assessments. We want to do follow-up appointments. We want to link them up with social worker, case manager. What do they need to know? Wound care at home, signs of infection to watch for, to call the doctor. Okay, we're saying this, importance of physical therapy and occupational therapy, nutritional needs, still hypermetabolic, sun protection for the skin, scar management. The goal is to get them back to the highest level of independence possible. Some patients return to 100% of their previous function, others need adaptation. But with good bone care and rehab, outcomes can be pretty amazing. Okay, friends, it's my favorite time of this. Let's test what we learned. Pause the video if you want to think through this. Question 1. A patient receives sheet autograft to both hands 2 days ago. Which nursing action is most important? A. Encourage active range of motion exercise. B. Keep hands immobilized and elevated. C. Remove dressings to assess grafts daily. D. Apply compression garments. If you said the answer was B, you're correct. B is keep hands immobilized and elevated. Immobilization is critical in the first 3 to 5 days to allow graft take connect with the blood vessels and to really merge. Movement can disrupt those new blood vessels forming. Elevation reduces edema, which can also compromise graft survival. Question 2. Your burn patient has circumferential burns to the right leg. Which assessment finding requires immediate intervention? A pain level 7 out of 10. P, cap refill 4 seconds. C, pedal pulses present but weak. D, skin is warm to touch. If you said cap refill 4 seconds, B, you are correct. Cap refill should be less than 2 seconds. Evidence-based practice now, but some hospitals still use less than 3 seconds. So less than 2 to 3 seconds. 4 seconds indicates compromised circulation. So they are at high risk for possible compartment syndrome. Remember the 5 P's. The patient may need an excreotomy or fasciotomy ASAP. Question 3. A child presents with burns that have clear demarcation lines on both feet and lower legs with no splash marks. The parents said the child's stepped in hot bath water 3 days ago. What is your priority action? A. Apply sulfadazine cream. B. Calculate fluid resuscitation needs. D. Document findings and report suspected abuse. D. Prepare for wound debridement. Now you see how NCLEX works. All of these questions, all of these options are right, but you need to choose the most correct one based on the detailed information they gave you. If you said C, you're correct. Let me tell you, if I was writing pen and paper, I would underline my red flags. Now, my red flags for this scenario, a patient child arrived with burn that have clear demarcation lines on both feet and legs. Remember the picture I showed you? There's no splash mark, dun underlined. The story is not storying. They said the patient stepped in hot bath water 3 days ago. Yes, your child stepped in hot bath water. Bring them in and let you know immediately. It happened though. At least few hours after it happened, but you had to wait 3 days. What is your priority action? Yes, you need to document findings and report suspected abuse. Because they delayed in seeking treatment, there's clear lines, no splashes. You need to document everything. You need to take pictures if protocol based on your facility or your hospital protocol, and you want to report to appropriate authorities. Yes, you will still treat the burn, but safeguarding that child is a priority. So yes, you'll still do all of that, but based on this question, and you know they're asking for a specific thing. Question 4, which patient should receive higher fluid volume than calculated by the Parkland formula? Remember, we did this in part 1. Watch part 1. In part 1, okay, so your option A, a 25-year-old with 40% flame burn. B, a 45-year-old with electrical injury. C, 60-year-old with scarred burns. D, 35-year-old with facial burns. The answer is B. Electrical injuries need more fluid because of deep tissue damages. Remember, this is the part where we said it's not what it's not what you see. I've forgotten how it went, but basically what I'm trying to say is deep tissue damage and myoglobin release. So target urine output should be 75 to 100 ml per hour instead of the usual 30 to 50 ml per hour. So our 45-year-old with electrical injury should receive a higher fluid volume than calculated by the Parkland formula, because our target urine output for this patient will be 75 to 100 ml per hour. Now, how did you do? Drop your score in the comments below. Now it's time for wrap up. And that is it, friends. We just covered so much in almost 50 minutes. I was hoping for 30 to 45 minutes, but let's recap real quick. Wound care goals and hydrotherapy, autografts, sheet versus meshed, complications like infection and compartment syndrome, special population, pediatrics, abuse, elderly, rehabilitation, and discharge planning. If your brain is full, good. Imagine how mine is. Good. That means you are learning. Now go back and watch the sections again. Take notes, make flashcards. Next week, we're moving to chapter 20, trauma. Whew. And then after that, we're going to be prepping for Kaplan pharmacology. It's all coming together. So getting closer to NCLEX and finals. Before you go, please like this video if it helped you. Subscribe so you don't miss the drama next week. Drop a comment. What is your biggest bond care question? Share with your classmates. Let us all do well and pass. Do not gatekeep. We all need to do. We need to help each other to do well. Remember, you're not studying alone. We are all in this together. We are going to be we're going to be amazing great nurses. Until next time, happy studying. Bye.